Thank you so much, everyone, for joining me today. As we discussed in prior meetings, our change for 2021 was to have a monthly topical discussion with targeted story prompts, discussion prompts. And we're going to do this through May. And so the first for this year is on this topic of reluctance of Black Americans to take the coronavirus vaccine. And as I was sharing with someone earlier, that it aligns with our resolution to look at systemic racism, whether it's police brutality, it also affects in the emergency room. I would like to start off with a prayer, if you don't mind, just so that we all are in the same frame of mind about looking at this through the lens of faith. Dear Heavenly Father, thank you for this opportunity to convene once again in your name. Touch our hearts and our minds and let us know that we are doing all of this to your glory in your name. Please help us discern the facts, discern influences in society as we make changes to glorify your name. We ask these things in your name and for your sake. Amen.
Amen.
So this is why we're here. And what we're going to cover today, it falls under three categories. We're going to put some facts around COVID and the vaccine. We're going to look at what I call the Black experience through the idea of health disparities, how this is showing up in the news, because that's where the story is told very often. And we have a very special guest all the way from Virginia who's going to be speaking with us in a few minutes. I won't steal the thunder, but her name is Dr. Patricia Lynch. Then we're going to have a discussion. We're going to hopefully time this out for about 20 minutes, and that'll leave us about 40 minutes to have some dialogue. If this gets particularly engaging, then maybe we can look at carrying it over in another session. So that's just like flight attendants, they tell you, if you're not headed to Iowa, please disembark now. So this is where we're headed. I want to give you some statistics, some numbers to kind of to give some context here. The total population in the world versus the United States. The total world is 7.8 billion people. In the United States is 331 million, and this is as of 2020. So our percentage of the world population is 4.2%. But the total cases compared from the world to the US tells a totally different number. Total world cases as of last night was around 100 million. Total US cases is 25.5 million. That means that we have nearly 26% of all of the COVID cases as compared to the rest of the world. We have a disproportionate contribution, if you will, or participation in this crisis. Let's drill it down to the United States. In the United States, as of last night, there were about 25.2 million cases of COVID. Almost 420,000 deaths related to COVID. And in terms of the vaccine, since about December when the first of the two vaccines was made available, 44 million have been distributed, but only 23.5 have been administered. Just over 50% of all that's available has been gone into an arm. And as a reminder, the US has a population of 331 million. So we are a long way from herd immunity. We're not even close to scratching the surface to getting this under control. Perhaps with this, not perhaps, with the new administration, there is a new focus on how vaccines are being ordered and distributed, and just in a week, maybe this variants may be totally different. But this is the state of the world where we are right now. In terms of the Black experience with COVID, there's a study by the Kaiser Family Foundation that said 35% of Black Americans were probably not or definitely not get the vaccine if deemed safe by scientists and widely available at no cost. So even if scientists say this is a good thing and it's free, more than a third of Black Americans are skeptical, reluctant, would not participate in this. That's alarming. Further on the idea of racial disparity, there are three major factors that increase the risk of COVID exposure that disproportionately affect racial and ethnic minority groups. The first is the neighborhood and physical environment. Evidence shows that people in racial and ethnic minority groups are more likely to live in areas with high rates of new COVID-19 infections. Secondly, housing. Crowded living conditions and unstable housing, homeless population perhaps, leads to the transmission of infectious diseases and can hinder COVID prevention. Thirdly, occupation. Racial and ethnic minority groups are disproportionately represented in essential work settings such as healthcare facilities, farms, factories, warehouses, food processing plants, and so there's a greater chance of exposure to COVID-19. Here's a chart that may be a little hard to read, but I pull it off of CDC, and it compares the likelihood of cases, hospitalization, or deaths for Black Americans as compared to white non-Hispanic persons. In terms of cases, you have 1.4 greater chance of having a diagnosis than for Blacks than for whites. 3.7 times greater chance of being hospitalized, and almost 3 times greater chance of dying from it. It is alarming in all the categories, but there's a particular history for Black people that makes that number almost exponential. These are the facts. These are the numbers. There's no kind of intuitive sense about how Blacks are affected by this. These are the numbers. Much of that hesitation can be tied to something that's been termed the Tuskegee experiment. The official name is the Tuskegee Study of Untreated Syphilis in the Negro Male. It was an unethical medical study conducted between 1932 and 1972 by the US Public Health Service and the Centers for Disease Control and Prevention, the CDC, the very organization we rely on to give us guidance and instruction on healthcare matters. The purpose of the study was to observe the natural history of untreated syphilis. African-American men who participated were told they were receiving free health care from the federal government. The men were told that the study was going to last 6 months, but it extended to 40 years. And after funding for the treatment was lost, the study continued without informing the men that they would never be treated. None of the infected men were treated with penicillin, despite the fact that by 1947, the antibiotic was widely available and had become the standard treatment for syphilis. The Tuskegee study was a major violation of ethical standards and is cited as one of the most infamous biomedical research studies in US history. The resultant distrust in medical science and the US government has reduced Black Americans' participation in medical studies and receiving health care. And even if African Americans were not alive during this study, even if they don't read history books, there is this ancestral baggage that we carry. We know some kind of way not to trust the US government or the medical community. Even if their grandparents didn't sit them down at their knee and say, don't trust the government. It's just, it's systemic, it's endemic in our community. Some of us don't even know why. But if you couple this history with all the other elements that I was describing earlier that put African Americans at a disadvantage, it's no wonder there is this distrust. This topic has hit the news, particularly in the last couple of months when the vaccine became available. The story is in the headlines. Just Google it. There are stories everywhere that mainly are kind of elevating this to people's awareness, but not really understanding the long history behind it. One example was a hour-long town hall conducted mid-December by CNN called The Color of COVID. They had then Surgeon General Jerome Adams and Dr. Fauci joined Don Lemon and Dr. Gupta on looking at the history and some of the questions from communities. It's an amazing hour, and I encourage you to Google it to hear some of the concerns that were raised in that session. But I just pulled a snapshot of storylines, headlines about this particular case from USA Today, Sentinel, which is one of the largest Black newspapers in LA, CNN. Amid access hurdles, grassroots efforts underway to get COVID-19 vaccine to at-risk people of color. Black physicians get vaccinated to build trust in science among high-risk minority populations. A Black doctor died of COVID-19 weeks after accusing hospital staff of racist treatment. That one showed up in the news. She actually had social media excerpts of what her experience was. So a doctor, a Black doctor who knew about COVID was not treated equitably, and she died. Racism contributes to COVID-19's double whammy impact on the Black community, according to Dr. Fauci. White people are getting vaccinated at higher rates than Black and Latino Americans. There was also an email I received just 2 days ago from a faith-based consortium associated with the Biden administration. They are looking to all these different constituencies to understand and persuade and influence taking the vaccine. And I wanted to offer my survey, my opinion, but they were offering $10 for the first 300 people. It took me 44 minutes to get to the survey, and by then it had already been oversubscribed. There is, now it could have been the money that was motivating people, but it shows that there are people putting money behind finding this, understanding this dilemma, the reluctance to take the vaccine. And I think it's particularly important for faith-based communities with African American members, congregants. More in the headlines. With painstaking effort, Black Doctors Group takes aim at COVID-19 vaccine hesitancy. That's from the an institution called STAT. CEO of Howard University Hospital, the large HBCU that is in the news of late for Vice President Harris. The CEO of their hospital took the vaccine to encourage staff and others to follow her lead. When Black people are wary of vaccine, it's important to listen and understand why. Dr. Fauci. He also went on to say he wants people to know that one of the lead scientists who developed COVID-19 is a Black woman, Dr. Kizzmekia Corbett. And so I suspect her work may be used to help persuade African Americans to take the vaccine. At this point, I would like to turn the discussion over to our guest, Dr. Patricia Lynch. She's the Associate Professor and Director of Didactic Programs and Dietetics at Virginia State University. Her research focuses on community nutrition interventions to alleviate health disparities. She works in a multidisciplinary research, outreach, and education to address nutrition and health disparities in underserved populations. She taught nutrition and food service for more than 15 years and has been part of research grants in the millions. She received her doctorate degree in nutrition from University of Nebraska-Lincoln, completed her master's degree in food and nutritional science from North Carolina A&T State University. But the most important attribute about our guest is that she is the sister of our beloved Reverend Leo Lynch. And I thank you, Leo, for hearing about the advanced discussion about this topic. And he asked if I would be interested in speaking with Patricia. And after we got to talking, I said, oh, absolutely. We would love to hear your thoughts on this. And now I would ask my moderator to put Patricia's screen up on so that everyone can see her and not my slideshow. Thank you, Patricia. Welcome.
Thank you. Well, what I want to cover a little bit is just talk about the disparities as it relates to my area, which is nutrition. When I talk about health disparities, I'm really talking about dietary patterns that are different, or dietary behaviors that may impact, or foods, or access to food. And I think most of the time when we talk about disparities, I always hear people talk about, well, this is the community that doesn't have a grocery store. And that's about all that you hear, but that's not all there is to nutrition and dietary disparities in minority populations. Now, although those things, it is important that we don't have grocery stores in particular environments, because when we do research, we always inevitably say African-American people are the least likely to eat the appropriate amount of fruit and vegetables. No kidding, how do they get fruit and vegetables? They don't own farms anymore. They're in populations or in locations where there are side street type places where they buy their food. They don't have necessarily fruits and vegetables at these places. There was one place that I visited here in Virginia that's a sort of like a mom and pop place. And what they had in there it was in the middle of an African-American community, but their fruit and vegetable consisted of wilted collard greens, and they had a lot of meat that was like hog head and knuckles and things that we assume that Black people eat. Now, so they think that if we cook some collard greens, we're going to put some, hog knuckles in it. And in places in America, that may be typical, but that should not represent every community when people need fresh fruits and vegetables, because there is none. And not everybody eats, hog knuckles, so they don't have choices, I'll put it like that. And it's not because they don't want choices, but I think the larger part of it is because we see people differently, regardless of what their ethnicity is. I think all of us come with biases. And I think the bias for African-American communities is one that it takes people a long time to get across to think about something else. If you say, tonight I heard on the news that somebody stole some money from the grocery store around the corner. In your head, most people's heads, I don't know about you guys, but in most people's heads, they don't even see the person, but they automatically assume that it must have been somebody Black that stole the money from that grocery store. And why do you think that is? First of all, some of it may be in the fact that we know that there are certain populations that are at the bottom of the socioeconomic status. They may be stealing to survive. That's one thing. But that doesn't make it right or wrong. But in our heads, it doesn't matter why they stole. But we always say that they're Black. They're a person of color for whatever reason, And then if the television come on and the person is not a person of color, this is what we hear. Oh my goodness. That person, that's a nice looking white kid. I wonder why he broke into this place and stole the money. Why would, but if the person is Black, they're criminal, and they are criminalized in a lot of our societies. And that's just the way it is. So when we think about, and I'm getting a little bit away from the food, but when I think about the food, it crosses some borders of health disparities, because what we eat, we know that probably, I think right now they're saying that the third largest disparity for killing, for mortality of people has to do with their eating behaviors, not just eating the way we eat and what we choose, but because the diseases that they get as a result of that, hypertension, high blood pressure, cardiovascular disease, chronic kidney disease, diabetes 2, cancer, colorectal, so there are a lot of things that are related to what we eat that causes high mortality. And when we think about the diseases that affect African Americans, let's say something simple as hypertension for other people, it may not be a big deal, but high blood pressure in Black people, we have research that we know that they get it at an earlier age. And when they do get it, it's more severe, and they tend to get no treatment or inappropriate or less treatment. So even in some of my earlier research, when I looked at hypertensive patients, some of the treatment they received wasn't appropriate enough for them to lower their blood pressure, although they took it. They take pills that the doctor told them to take to reduce their blood pressure, but their blood pressure wasn't going down. So what is the purpose of that? So any chemical that we take will leave a negative impact. Maybe it should have been there to do something. But what has happened over the years is obviously more research has come out. There are things in different populations that require different types of medications. So for a lot of African Americans, there are like a two-step medications. I mean, they need to be given 2 or 3 types of medicines in the beginning prior to the way we would give it to, let's say, a Caucasian individual. And most doctors didn't know that because a lot of the doctors were older people and they weren't, I don't want to say that they were insensitive to African American, but they were using the same guidelines to treat all their patients. And it's not the same. Some people, some segments of the population need something different. We know that when we look at Native Americans, they have a higher rate of diabetes. So we have to do something different with that, but for African Americans, they're in the middle of a place where there is something in this country that says, whatever you have, you almost deserve it, or we're going to do something. So when you brought up this topic about COVID, a lot of the people that I speak with, they may not take it because they have been in places where they've been experimented on. And I'm not even talking about the one that Cheryl brought up, because that one was outrageous. And we're talking about men, but there are an extreme number of research projects that looked at Black women, for example. For white women, it's easy for you to maybe have a cesarean there, but who do you think the first clinical experiments were on? Childbirthing has never been easy for anybody. So when you start looking at some of the surgeries that were done without permission or anything, who do you think the experiment was? We weren't using animals, we were using people. And those people were not really considered human or citizens of the country. So, so when you look at those types of things, and then you have mental health, for example, a lot of the mental health experiments were done on Black folks because they thought we were crazy anyway. And I'm saying we because I'm African American, but for Black folks, there was a lot of them that had brain surgeries for just to be experimented on. Of course, if they were crazy, if you can imagine somebody opening up your head to make a test so that it could help the other part of the nation, you're just an experiment right now. So let us use your body to see what happens. I mean, and when you think about the children of these children's children, of course they're going to tell the story. Why would they not tell the story? They've been examples of experiments. And I'm not saying that you can't walk around the corner today and find somebody doing some crazy experiments. I mean, because we're in a different world at a different time, but that doesn't change the feelings that people had at the time that they know of their family. I mean, imagine something terrible happening in your family or in your heritage that you don't ever want to talk about again. You don't even want to hear about it, but you remember it because it was so painful. And you don't ever want that to happen to you or your family member or anybody else in life. So you remember. So when someone comes up to you that you don't trust, you don't know them, and they don't look like you, and they ask you to take a shot, or in my case, eat this new vegetable, or take this soup that I'm offering, or this new supplement, they're going to look at you like they're crazy. It's like, and what is it supposed to do? Because you never feel that if you're offered a supplement or a medication or something, that you're not going to get a good, and even me, now I'm a PhD person, which where I am is sort of like you're at the top of the chain in your educational status. But it doesn't change the fact that if I went to a doctor at any given point, somebody that I don't know, and I'm not saying the doctors that I do know, because I make a point of making sure they know who I am. But if I go to see a doctor and they don't know who I am or anything about my background, they're going to start telling me what they think that I should know about anything. You know, it could be about nutrition. That's my field. But if I never say that I'm a nutritionist or a dietitian or professor of nutrition, then they're going to say, well, you just need, and this is an example from my family. My mother is, or was at some point, 20 years ago, she was obese. And one of the things, and I was even in nutrition at that time. So what I would tell my mom is, Mom, you need to go see a doctor, and this is what we're gonna talk. She was having knee issues. She had to have knee surgery. So she goes to the doctor. I didn't go with her. She goes to the doctor, and when she comes back, and she has her little paperwork, and I asked her, what did the doctor say? She said, the doctor told me, unlike what I told her, because I'm specific, the doctor told me that I should watch my weight. Lovingly, I should watch my weight. And I'm, in my brain, what does that mean? What does that mean to anybody? If a doctor tells you to watch your weight, I mean, what does that really mean? Does it mean that you are overweight and you need to lose 5 pounds? Does it mean that you can eat whatever you want and just look at what you're eating? I mean, should you just get on the scale every day and just watch it? I mean, what does that mean? And my mother's not an educated woman. But for a doctor to say something like that and it's not just her, she just happened to be a single person, but just in general, the information is not available, and it may not be at a place where people can understand it. Now, I did research on obesity.
Excuse me just a minute, Patricia. I want to, I'm loving everything you're saying. I want to
Am I going too far?
No, please don't apologize. I want to make sure that we've got about 25 minutes, and I want to make sure we give folk time to process this and ask you some questions. I love the point you brought up, though, about all of this history runs to the front of your mind when the question is about the vaccine. Like, it's not just about the vaccine, it's all the history, all the stories, all the personal experiences that affect it. And that is the perfect context for this discussion. So thank you. Now, I want to cut you off. You had a closing comment you want to make there?
Well, I guess my closing comment is, I think all of us, we need to look at people as individuals and talk to them as though they're important, like they're your sister, your brother, your next door neighbor, or whatever, rather than saying, you're in this population, and if you're obese, I don't need to tell you how to lose weight, because we expect Black women, they're supposed to be obese. So, because they told us that they enjoy being fat, so that's what I have, that's the end of what I want to say, because that was what my research showed, that a lot of the physicians don't talk to Black women. If you're a white woman or if you're a white male, they'll tell you your BMI is 25, your BMI is this or whatever, you need to do this or you're good. But if you're a Black woman, just watch your weight.
Right.
That's it. So
right.
That's it.
No, it's wonderful. Thank you so much for that. It goes to this point about being our own best advocate, no matter what color or gender we are. I've had to push back many times when something didn't make sense to me. And a lot of people don't count on you being inquisitive. But all of this is relevant to this topic about the vaccine. Now I want to put up this final slide and open it up to everyone to, hold on, just see, I want to make sure, put this final slide, make sure, open it up for our discussion. And that is this. So in summary, racial disparities in healthcare cause a reluctance of African Americans to take the coronavirus vaccine. So I want to throw it out to everyone here to speak on one or both of these questions.